it appears that both intolerance with adverse events that are distressing to the patient, albeit low grade, can be an issue. But there also are some major cardiovascular events that include hypertension and atrial fibrillation that are relatively high in the, if you will, lead drug, Ibrutinib, which has been the BTKi that's been used, tested and used the most. So intolerance occurs in clinical trials that where the level may be anywhere from perhaps reported as 15 to 20 or 25%. I don't have those exact numbers in front of me, but I think that's pretty close. On the other hand, intolerance, as reported in the real world, that is outside of clinical trials, may be as high as 40%. And that's been evaluated extensively by investigators like Anthony Mato, and also our own group here at Mayo Clinic has reported that intolerance can be a dominant reason for discontinuation, particularly of Ibrutinib. And then the other reason for discontinuing BTKis would, of course, be disease progression. The good news there is that disease progression is relatively rare in the first several years of an individual getting a BTKi, but it can occur, and perhaps is seen in ultimately 15 or 20% of patients, but this is after several years of receiving the drug. So disease progression is I think all in all, a lesser reason for discontinuation, but can definitely occur. And that would be true for both the Ibrutinib as well as acalabrutinib.